Okay, well, I don't know who the next is, Dirk Timmerman from Leuven, who I think we all know. So I'm looking forward to Dirk's talk because the latest IOTA trial is IOTA 5. Clearly, most of the data you've heard so far is to do with IOTA has applied to masses that have been removed surgically, and of course those studies were done that way because the gold standard was histology as the endpoint. However, the question is what happens first of all when you apply IOTA models or indeed any model to patients who subsequently are managed conservatively. You know, do you get the answer? Do you get it right? And what happens to these tumours over time? So that's the sort of question IOTA 5 has been trying to answer, and I think Dirk has some of the first preliminary data from the trial. So this hasn't been heard before, so look forward to hearing it, Dirk. Thank you.
Thank you. And first of all, let me thank many people in the room contributing to this study. So I think, as I was last week, you're very eager to know what are the results of IOTA phase 5, because it's been ongoing since 2012, and this is a just-in-time delivery. I was assigned this title to give this lecture, but last week I had no results. So I'm very grateful to my colleagues, and especially Wouter Voyman and Karl Andolfo, to do this very speedy data cleaning, and for all the centers to give all the feedback and all the problems that were with the data, so to solve them. And so I think we can now give a pretty good interim analysis. As you know, IOTA 5 is a long-term follow-up of non-operated masses, and also an external validation of models and simple rules in different types of centers. And we would like to see whether we can come up with an algorithm that fits all types of tumors, also the non-operated ones. And as you can see at this moment, there's 43 centers contributing, and there's a few new that have not submitted their data because they only recently started in Vienna, in Israel, in India, and in the USA. But we already have a pretty high number of patients from throughout the world. And you can see there's a good geographical spread of contributing centers to IOTA phase 5, 17 countries. And we were very much surprised to see that we already have 8,359 patients, of which 3,722 underwent surgery, because at first scan it was judged that the tumor would better be operated upon, and 4,479 went for conservative management. So what happened to these? Because this is the main result of IOTA phase 5. Is it safe to leave in patients where we know there's a tumor and where we will not do an operation? So overall recruitment continues, and it's even speeding up, so it's almost like a logarithmic scale or an exponential scale. So we first had 5,000 in the end, in March of 2014, and over the last year we recruited over 3,000 new patients into the study. Then here in red you see the surgical treatments, and in green you see the patients that are followed up with conservative management. Age distribution is, as we might expect, there's no under 18s because this was simply an exclusion criterion. We have some, but we didn't take into account them into the statistical analysis. There were also 204 pregnant patients, and the majority of them were not in the surgical group. So during pregnancy, we try not to operate. So this means that 1% in the surgical group are pregnant and 3% in the conservative group. 40% in the surgical group were postmenopausal, 36% in the conservative group. And of course, much more patients had symptoms in the surgical group compared to the ones in the conservative group. What do these tumors look like? Are they all unilocal cysts? No. You see all the types of tumors that we see in the surgical group, where we had 30% of unilocular, 12% unilocular solid, almost 18% multilocular, 19% multilocular solid, 19% solid, and 1% unclassified. Well, in the conservative group, only 60% were unilocular. There were almost 6% unilocular solid lesions, 22% multilocular, cases, 3% multilocular solid, and 7% solid tumors. So this is quite daring, because knowing the risk of malignancy in this group, it's quite strange that we have so many patients referred for conservative management. But the indication was, for conservative management, if you think as a sonographer or ultrasound examiner that it's a good idea to have conservative management, that we would propose this. Again, if you look at unilocular solid, multilocular, you see that there's less in the surgical group and more in the conservative group in the unilocular cyst, whereas multilocular solid, there are more surgeries and less conservative management. Some patients already have 8 ultrasound scans, but the vast majority had 1 scan, 2 scans, 3 scans, and then you can see the percentage in the conservative group. And after each scan, almost 5% gets surgery. So after the first scan, 5% got surgery. After the second scan, 8%, 4.8, 4. So this means every time the patient comes back, she has almost 1 chance in 20 to be referred for surgery. And in total, 10% of patients got surgery. So this means 1 in 10 of the patients that were initially designated to the group of conservative management finally had surgery. And this is ongoing, so in the future this might be higher, but at this moment it's 10%. And is it always because the surgeon is willing to operate? No, there's patient request. In 97 cases after first scan, it was a patient who requested to undergo surgery. So this is 40% of total. In 26%, it was because of chronic pain, 12% because of suspicion of malignancy, which was not suspected at the first scan in the majority of cases. Sometimes there were fertility concerns, and this is mainly in endometriomas. So the patient has infertility or subfertility, and then the endometrioma is operated upon, not because it's painful, not because it's giving a risk of malignancy or not malignancy is suspected, but because of fertility concerns. There's also opportunistic operations. This is, for example, if a patient needs to undergo surgery for other reasons, for fibroids, bleeding, hysterectomy, and then they simply remove the ovaries at the same time. So this is not because there's an ovarian cyst. The ovaries are removed opportunistically. There's also some patients with acute pain, suspected torsion, and so here you see all the results. Some patients had abnormal CT scan or MRI, but this is only very, very rare. And what type of histology do we see in the secondary surgery in the conservative group? Well, 84 had an endometrioma, so that's almost 20%. 17% had serous cystadenoma, 15% had a dermoid, 11% simple cyst. Then there were mucinous and serous cystadenomas, cystadenofibromas. In total, 96% had benign histology. On the other hand, there was 4% borderline or malignancy. So this is quite frightening, what happens to these patients. So we will go into detail. First, let's look histology. 10 borderlines, 3 endometrioid adenocarcinoma, 2 borderline mucinous carcinoma, 1 serous adenocarcinoma, and 1 not gynecological malignancy. First, let's concentrate on the borderlines. 5 of them were suspected to be borderline or malignant at the first scan, and still they went for conservative management. Why is this? Well, in 2 cases, it's because they were pregnant. And they said, it's a borderline tumor, or probably a borderline tumor, but the patient is pregnant. We wait till after pregnancy, and then we will remove the tumor. And there were 3 other patients who were not pregnant, but they had a history of borderline tumor. Well, actually, 4 out of 5 of these patients had a history of borderline tumor. And if a patient, for example, has already had an oophorectomy on one side because of a borderline, then you're much more careful to remove the other one if you're not absolutely certain that it's a borderline or malignant, certainly if she's only 25 years old. So here you see 34, 35, 29, and if they're not had completed their pregnancy wish, it might be much higher to have a threshold to operate upon them. But finally, they got an operation, despite the fact that it was probably malignant, probably malignant, probably malignant, at the first scan. And these patients had all borderline tumors. Then there's a second group, and this is the new malignant diagnosis. And then, of course, you can say this is a false negative, it was missed at the first scan, or it might be a malignant transformation. It might be a benign cyst that changes over time and it transforms into a borderline malignancy. Well, is this feasible? Yes. There's 2 cases that had no delay, no follow-up time. And this is because the ultrasound examiner at the time of the scan said, I think this patient can go for conservative follow-up, but the clinician said, no, I want to operate on this patient immediately. So this happened to 2 patients. So there was no delay in diagnosis because of this clinical judgment. Let's exclude these patients and focus on the remainder. There's 6 other patients with borderline tumors. Some had certainly benign, uncertain, certainly benign, probably benign. And after some time, in some of them, the tumor morphology changed. This is after 24 days, so it's quite difficult to understand why a benign tumor would change into a borderline in 24 days' time. So probably we can classify this one as a false positive diagnosis. On the other hand, there's 2 patients where there were no changes in follow-up. So the morphology was exactly the same after 92 days and 156 days. So again, probably if the morphology does not change and finally it proves to be a borderline tumor, probably it's a false negative. The diagnosis was missed at the first scan. And then there's a few patients where the tumor morphology clearly changed from benign looking. Here it was unilocular, solid with papillations without flow, and then it was changed, and then they said it's probably malignant. But this took 2 years. Then there's another case, unilocular, anechoic, and then it became unilocular solid with papillations. So if you have a clearly unilocular cyst without papillations, and you see papillations coming, this might be malignant transformation. We cannot prove this, of course, because we don't have histology, but you may suspect that it's a transformation. And again here, unilocular, no papillations, and then it becomes unilocular solid with papillations, and it proves to be a borderline tumor, and this is after 1 year of follow-up. So I think there's a few cases indicated in red with the red arrows where we can suspect that there was malignant transformation, and we know that this is possible, and the others might be false negative diagnosis. But we will never know for sure, but we can speculate about this. And then most importantly, there's 3 cases of invasive tumors. So there's, again, possibility that these are false negatives or malignant transformations. And we will look into detail in these cases. Unilocular anechoic, probably benign hydrosalpinx, and I will show the images of this patient in a second. Multilocular anechoic, certainly benign simple cyst, and 2 years later, it becomes endometrioid adenocarcinoma. So this might be a malignant transformation. And then finally, unilocular anechoic, 2 months later, proves to be serious adenocarcinoma stage 3B. So what happens in this case? So I think we have to focus on case 14 and case 16, because these are terribly important. Case 14. What do you think of this image? Can you see the image? What does it look like? Hydrosalpinx. And here you see the beads on the string, Does this look like a malignancy? No. Same patient, 2 months later, what does it look like now? So there's a clear change in morphology. So even despite the fact that this is only 2 months later, you have the impression that this is a clear transformation of the benign tumor into a malignancy. But we'll have to discuss this. And these are really the first results. But I think 2 months ago, you cannot suspect a malignancy. And then suddenly you see these papillations inside this so-called hydrosalpinx. And this was endometrioid adenocarcinoma. Then case 16 is a very special case as well. She was 62 years old. She had a previous hysterectomy. There were a lot of adhesions. And it was a case that we've seen in Leuven here. And this looks like a small cyst, 17 millimeters by 23 by 17. This was fixed to the pelvic side wall. There was no ovary visible except for this. So this looked like an ovary surrounded by adhesions, or it might be hydrosalpinx, because very often after hysterectomy you see a hydrosalpinx. And it was said, so it's either a unilocular cyst next to an ovary, or it could be unilocular solid, but this is much less likely. So it was judged to be something that certainly needed follow-up, if no surgery. And here again, you see the solid area, which was thought to be a normal ovary, 13 by 9 by 10 millimeters. That's it. This patient came back 62 days later, and now the whole cystic structure has grown to 29, 22, 21 millimeters. And this so-called ovary is still there, but there's a lot of solid tissue developing in there as well, and there's several papillations formed. So the solid tissue is here, papillation is here, papillation is here, and this was a tubal carcinoma, also with stick, so tubal interepithelial carcinoma, and unfortunately she had stage 3, it's not 3C, it's 3B, and these were very small implants throughout the peritoneal cavity, very small. So this patient got full debulking surgery. The surgeon was confident there was no residual tumor. And then the question is, where does it come from? So most likely she had tubal intraepithelial carcinoma with spread of these cells throughout the abdomen, very small implants. And 2 months later, these implants had grown, of course. But the primary tumor had changed as well. There was a clear difference if you compare this. This is another case of tubal carcinoma, where you see the fimbria here, the tubal carcinoma, ascites, an almost normal-looking ovary, and despite this fact, you see omental cake and spread in the peritoneal cavity. This was a patient outside of aorta 5, the last image. It's simply to show that sometimes you can see tubal carcinoma, but in most of the cases we don't see it. And this is the problem with screening studies, like shown by Professor Menon. There's a difference between type 1 cancers that may develop from pre-existing lesions and the borderlines that we see here that develop from benign tumor into a borderline cyst. These are type 1 cancers. And the prognosis is good, and probably delay of diagnosis for some months does not play a role in survival of the patient. On the other hand, there's type 2 cancers, very aggressive cancers. A lot of them are developing into the fallopian tube, and with no means you will find them very early because they're already spreading into the peritoneal cavity. But overall, if we look at risk on complications in conservative group, we know that out of 4,500, 450 patients were operated upon. There were 11 cases of confirmed torsion. This is 0.2%. 2 patients out of 1,000 with a benign tumor that was conservatively followed up had torsion. And yet, this is the main reason why gynecologists are convincing their patient to operate a cyst. Beware, because you have a risk of torsion. So this is very rare. Confirmed cyst rupture, even more rare, 4 out of 4,000. So this is 1 in 1,000 patients. And then borderline malignant outcome, this is 0.04%, so 2 cases, 6 cases here, the borderlines doing follow-up, false negatives or malignant transformation, and 1 in 1,000 will finally prove to have a malignant case. So this is 1 in 1,000. But if you then go to risk of complications in surgical treatment, and this is a slide from Jeroen's thesis, clinical practice is highly variable. Many clinicians operate on simple cysts, and yet we don't forget about complications. There's pulmonary embolism, deep vein thrombosis, bowel perforation, and remember that the first screening study, the European randomized trial for ovarian cancer screening, was stopped after several months simply because of 2 deaths from removal of benign serous cystadenomas, bowel perforation, and patients died. So it happens, and there's mortality related to benign surgery. And if we look again at a prostate, lung, and ovarian cancer screening study in the United States, then we see that there's 15% complication rate in patients with benign tumors, and 45% of complications in patients treated for cancer in the screened group. Infection, direct surgical trauma, cardiovascular, and others. So if we then see that cumulative deaths were even higher in the intervention group, this means that maybe part of the mortality is related to surgery for benign tumors, and that all the benefit that you do by removing these cancers, hopefully in an earlier stage, is diminished by this unnecessary surgery. So ovarian cancer screening may be very useful, but then you have to reduce the number of unnecessary surgeries. And if we look at costs, there's a recent study from Canada where they said cost of salpingectomy in total is 9,000 Canadian dollars. If we compare this to the euro, it's 7,330 euros. And if you then look at the overall picture, if you do surgery in 100% of your patients, the cost of surgery per patient will be 7,330 euros. Morbidity, 15% of complications. Mortality, I don't know. We don't find the figures. We looked into the literature, but we could not find good mortality figures in patients undergoing surgery for benign tumors. In the follow-up group, if you say ultrasound scan in main European countries is 50 euros, and if you do a scan after 3 months, after 6 months in the first year, and then a yearly follow-up, then you pay 600 euros for 10 years follow-up, and maybe after 10 years of follow-up, you can stop doing follow-up. We don't know, but at IOTA 5 we will say in the future whether this is sensible to stop the follow-up of these patients. Then morbidity is none, because you don't do any intervention. And mortality due to delayed diagnosis, we don't know. But when looking at the data that we had just before, then I don't think that many patients will have a worse prognosis. Maybe in the last patient that we discussed in case 16, so to say, there is a delay in diagnosis of 60 days. Will this make a difference for this patient in terms of survival? We don't know. She had full debulking surgery. The tumor was completely resected. 30 or 60 days earlier, probably the tumor was also disseminated. And the question is whether there's really a delay, whether this delay is really very significant in terms of mortality. So this is something we cannot calculate at this moment. But if we had done surgery in all our patients in IOTA 5, we would have had 675 serious complications. We would have had a cost of 33 million euros simply for surgery, and we would probably have several cases of mortality very close and related to the surgery. On the other hand, now the cost is only 1/10 of these patients in follow-up, 3 million euros, 67 serious complications because you still had to do surgery in 10% of the cases, and the late diagnosis, it's very difficult to say this. But there's also a long-term morbidity and mortality related to removal of benign tumors, and certainly by removal of the ovaries. if you do BSO by the age of 35 years, then the mortality risk of this patient is, the hazard ratio is 1.2. So this is a very large increase in mortality from all causes in these patients. Certainly if she's not given hormone replacement therapy. There's another study here, prospective cohort study on 30,000 patients in the Nurses' Health Study, follow-up for 28 years, hysterectomy for benign disease, and part of these patients had hysterectomy with bilateral oophorectomy, others had no BSO. And then you see that from all causes is clearly higher in the group where the ovaries were removed, 16.8% versus 13.3%. So you increase also the mortality rate in the surgical group if you remove both ovaries just to play on the safe side. And that's what happens very often if they do surgery, 45, 46 years old, they remove both ovaries. Many patients don't take estrogen replacement therapy and they will have a higher mortality from other causes. And what is it? They will have lower risk of that from breast cancer because of lower circulating estrogens. But on the other hand, they will have a much higher risk, 1.4, of having all-cause mortality. There will be a higher risk of lung cancer mortality and a higher risk of cardiovascular mortality. And this is even 2.3. So my conclusion here is that the current status of recruitment is promising in the way that we are not doing harm to our patients by following them up. And yesterday we had a vote during the investigators meeting, and all people voted in favor of continuing the study. We will do it again with a steering committee. But I think it's really a sensible option not to operate on all these patients. Certainly, the risk of torsion and cyst rupture is low. There's also a low risk of malignant outcome, and in some cases, there might be false negative scans, and in others, there will be a real malignant transformation after some time. But also, this seems to be quite low. But in the future, of course, we have to optimize our data inclusion, and for this, we will give feedback to all centers. We have to describe criteria to safely select patients, and maybe we need to be even more strict in referring for conservative management. And if there's any doubt in terms of malignancy, better operate on them, maybe. So that's something we have to see. And then we will validate existing IOTA models on all patients, and then hopefully we can give proper evidence-based medicine guidelines and management protocol for all adnexomases. Thank you.
Dirk, many thanks. That's great. Any questions from the floor? I mean, it's kind of quite. Where's the question? Sorry. Is there one?
I think we have to do the coffee break, and then we don't have much time.
Dirk, thank you for a really lovely presentation, and I'm so happy with your talk because it brings us closer together, me coming from the screening side and you coming from this side. And this is what I alluded yesterday when I spoke during the PhD, that as you detect earlier with case 14, you probably will you need to change some kind of I don't know, if you saw lots of masses, as you got to know, it'll take a long time for you to see lots of masses like that. But it'd be great to try and think about how we manage that. And that probably looking at that, you can see what happened in the screening study because it was normal. And then you have, in that 12 months that went on between the next one, you have these growths. As far as mortality and morbidity for your, I don't know if you were going to publish, in which case, in ours, the complication rate in the benigns, and it is in the paper, was 4.5%. I think there's a very major discussion about why PLCO had 50, and there were no deaths. But having said that, of course, conservative management would always be economically much more favorable than surgery. But if you wanted to make it a bit more realistic than PLCO, when you do your modeling, it may be that for Europe and for the sort of setting we are working in, a 4.5% complication rate.
Well, that's a good point. And what is a complication? Fever after surgery, is that a complication of infection? This is,
Yes.
but if a patient has bowel rupture and peritonitis, this is a serious complication. So there's some definitions that might differ, and that explain differences in reports. But PLCO was 15%. You have 5 to 6% risk of complication. But even then, it's 240. And if these are serious complications, then it's related to mortality. But mortality is very difficult to find. We looked very hard in the literature, but perioperative mortality figures are very difficult to find.
So
Okay,
in our whole trial, luckily, I have been waiting. You know, we did predict we might have one death. We
Okay, I
have
think
had no deaths.
I'm going to move on.
and
I'm going to
that
move on from this point because we're going to close. Because I think we understand the point about that. I just got Jan Franco is going to make a point. I think you asked a question, didn't you?
Thank you. A quick comment from the pathological point of view. I think that your results are fantastic because I would like to remember that borderline tumor stage 1 are benign, and it could be represented an endpoint for screening in type 1 carcinoma. And you have only one cases of 3C stage from tubatic carcinoma, probably. I think it would be very important, the familial history, because in most of these cases, there is mutation of BRCA1 and BRCA2. So when perform an ultrasound, I think it's very important to know the family history and to look with attention this case where there is a history of breast cancer or ovarian cancer in the family. And when the cancer is tubatic, as in your case, the possibility of BRCA1, BRCA2 is very high. So I think it's another important information in your data.
Yes, you're absolutely right. The threshold in patients with BRCA1 and 2 should be much lower to operate upon, and simply as a prevention for cancer. But then the most important procedure is to remove the fallopian tube. And there's now a very good, this Canadian study that calculated how much it would save costs if instead of doing tubal ligation for sterilization, you would do the tubal resection. So better remove the fallopian tube and leave the ovaries inside.
Okay, so final question. I mean, is there any data through yet on the analysis in terms of stratification and stratifying the masses so that some morphological subtypes or age or whatever are more likely to be associated with cancers down the line? I imagine that analysis hasn't been done yet, but it will be.
We will certainly do this.
Okay, I think we're going to have to close. No, I'm very sorry because we're running too late. Yeah, when?
Well, it was not fair, I think, to the lunchtime symposium that everybody was very hungry. This moment, we have the same problem again. We have a very good speaker from the United States. He gave a lecture over lunch. We said at the end of the coffee break, you can give the lecture in 10 minutes time to highlight the main points. But at this moment, we're running late again, and I think many of you are dying to have a coffee and maybe to go outside for a few minutes. So I propose that we do this for 10 minutes, and that then you try to be back to listen for 10 minutes to the talk about probe cleaning, because at this moment, we don't know what we're doing with ultrasound probes and in terms of bacteria and viruses that are transmitted from one patient to the other. So I think for this, I think it's an important message. And so let's try to be back in 10 minutes to listen to this.